Welcome back, focused learners. Today's explainer is an absolute deep dive. We're going to master the seriously dense anatomy and manual muscle testing of the lower extremities, specifically focusing on the foot. We're breaking down the definitive texts on the subject into clean, highly organized clinical concepts. It's not just about memorizing a list of muscles. We are going to understand exactly how they move, how to isolate them in a practical setting, and what literally goes wrong when they fail. Okay, let's dive into this. Our functional roadmap for today covers 4 parts. 1, muscles of the great toe. 2, the lesser toe muscles. 3, the intrinsic stabilizers. And 4, clinical deformities. Starting right off with section 1, muscles of the great toe. This is your foundational foot anchor. You know, the hallux, or great toe, is way more than just a digit. It's your primary anchor for arch support and that crucial push-off during the gait cycle. If the muscles here are compromised, your entire kinetic chain pays the price. So let's establish our rhythm right here, looking at origin, insertion, nerve supply, and action, or OINA for short. First up, the abductor hallucis. It originates back at the calcaneus, inserts on the medial side of the proximal phalanx, and is innervated by the tibial nerve, specifically nerve roots L4, L5, and S1. Its partner, the adductor hallucis, has both oblique and transverse heads originating further down on the metatarsals, inserting on the lateral side of that same proximal phalanx, and it's driven by tibial nerve roots S1 and S2. So, how do we actually translate that anatomy into a manual muscle test? Well, picture this. Your patient is either supine or sitting. As the examiner, your fixation requires you to grip their heel firmly. For the test itself, you want them to abduct the big toe away from the midline of the foot. Now, this is pretty tough for most people to isolate voluntarily, so you'll apply pressure against the medial side of the first metatarsal and proximal phalanx to resist their movement. Do this right, and you can literally feel and see the muscle pop along the medial border of the foot. Now, what's really fascinating here is how cleanly our 2 great toe flexors are separated anatomically. Both get their nerve supply from the tibial nerve, but check out the insertions. The flexor hallucis brevis stops short at the base of the proximal phalanx, meaning it only flexes the metatarsophalangeal joint. But the flexor hallucis longus, that tendon travels all the way down to the plantar surface of the distal phalanx. That gives it the power to flex that final inner phalangeal joint. And because of that specific anatomical difference, our manual muscle test has to be highly targeted. You can't just push on the toe to test the longus. You actually have to stabilize the metatarsophalangeal joint in a neutral position first. By locking out that proximal joint, you completely isolate the distal movement. Then ask the patient to flex the toe, and you apply pressure right to the plantar surface of the distal phalanx in the direction of extension. Let's play a quick game of symptom spotting. What actually happens when these flexors fail? Well, if the flexor hallucis longus shows weakness, the toe tends to drift into hyperextension at the interphalangeal joint. It kind of leans into this hammer toe position, which definitely decreases foot inversion strength. On the flip side, if you're dealing with a contracture, where the muscle is locked in a shortened state, it aggressively pulls that great toe down into a rigid claw-toe deformity. All right, flipping over to the top of the foot, let's talk extensors. Notice the big shift in the nerve supply here. We're now dealing with the deep perineal nerve for both. The extensor hallucis longus originates high up on the middle of the fibula, dropping this long tendon down to the distal phalanx to extend the entire toe. The brevis, on the other hand, is basically a medial slip of the extensor digitorum brevis. It originates way down on the calcaneus and only reaches the proximal phalanx. Testing these extensors is pretty straightforward. You stabilize the foot and slight plantar flexion. Then you just have the patient point their big toe up toward the ceiling, extending those joints. Your job as the clinician is to apply downward pressure on the dorsal surface of the phalanges, right in the direction of flexion. If there's weakness here, they lose the ability to extend the great toe, and you'll typically notice a drop in overall ankle dorsiflexion too. Okay, so we've mastered the main anchor of the foot. But managing one large digit is entirely different from mechanically managing 4 smaller ones at the exact same time. So how do we apply these exact same anatomical and testing principles to the rest of the digits without getting completely lost in the weeds? Let's see how this builds in section 2, muscles of the lesser toes. We're looking at digits 2 through 5. Here we've got the complex flexor network for the lesser toes. Similar to the great toe, there's a brevis that inserts on the middle phalanx and a longus that runs all the way out to the distal phalanges. But pay really close attention to the quadratus plantara here. It originates on the calcaneus and physically inserts right into the tendon of the flexor digitorum longus. Its whole job is to modify the line of pull for those longus tendons, ensuring your toes pull straight down instead of curling at some weird diagonal angle. It's a brilliant piece of engineering. When we go to test the flexor digitorum longus, we start by stabilizing the metatarsals. But here is a massive clinical pearl for you. If your patient has tightness in their gastrocnemias, you absolutely must have them flex their knee. This creates slack in the calf muscle, which lets you get the foot into a proper neutral position. Once stabilized, the patient flexes their toes, and you push up against the plantar surface of those tiny distal phalanges. The clinical signs of failure in this group are highly structural. Weakness in the flexor digitorum brevis doesn't just give you weak toes. It severely undermines the muscular support for both your longitudinal and transverse arches. Longus weakness leads to distal hyperextension and a tendency for the foot to pronate when bearing weight. And contracture, just as you'd guess, it permanently curls those outer four toes into a rigid flexion deformity. Moving to the dorsal side, we find the extensor digitorum longus and brevis, both supplied by the deep perineal nerve. The longest originates way up on the lateral condyle of the tibia and the fibula. But what's really fascinating is the peroneus tertius. It shares the same nerve and originates right alongside the longus. But instead of heading to the toes, it hooks into the base of the fifth metatarsal. Its actual job is to dorsiflex the ankle and evert the foot. To physically test this extensor digitorum group, you stabilize the foot in slight plantar flexion, just like we did with the big toe. The patient tries to extend all joints of digits 2 through 5. You just lay your fingers across the dorsal surface of those toes and apply downward pressure. If you happen to see the long arch collapse into a flat foot during your exam, you'll very often find accompanying weakness right here in these toe extensors. Think about this for a second. We have these long cables pulling the toes up and down. But if you pull a string that's attached to a multi-jointed structure, it naturally wants to buckle and claw. So what dynamically stabilizes the transverse arch and stops our toes from just curling up every single time we take a step? The answer is in section 3, intrinsic foot stabilizers. Specifically, the lumbricales and the interossei. This right here is where the fine motor magic happens, all orchestrated by branches of the tibial nerve. We have 4 lumbricoles, and they uniquely originate right off the tendons of the flexor digitorum longus. Their action is super specific. They flex the metatarsophalangeal joints while actually assisting in extending the interphalangeal joints. Then we have the interossei. Just remember this golden rule. Dorsal interossei abduct the toes, pulling them apart, while the plantar interossei adduct them, pulling them together toward the second digit. So the crucial point is exactly how you test them. Since the lumbricales flex the proximal joint while extending the distal ones, you stabilize the mid-tarsal region and ask the patient to flex from the knuckles of their toes, but they have to keep the tips perfectly straight. You apply upward pressure on the plantar surface of the proximal phalanges. Honestly, testing this specific strength is absolutely vital if someone comes into your clinic dealing with metatarsal arch strain. Moving into our final stretch, section 4. Clinical weakness and deformities. This is what it looks like when these foot muscles fundamentally fail. Now that we've mapped out the healthy anatomy, what happens when these muscular pulls get permanently out of whack? The clinical terminology actually tells you exactly which joints are failing. Let's define a couple of the heavy hitters. Talipes equinovarus, which you probably know as clubfoot, features an ankle joint locked in plantar flexion with the foot itself harshly inverted. Contrast that with Talipes cavus, where the ankle joint is dorsiflexed, but the forefoot is driven deeply down into plantar flexion. This creates an exceptionally high, rigid longitudinal arch. And this brilliantly illustrates just how binary some of these mechanical failures really are. Look at the stark contrast between valgus and varus deformities. In Talipes valgus, the muscular balance fails outwardly, the foot everts, and the longitudinal arch just completely collapses and flattens out. In Talipes varus, the imbalance pulls inward. The foot aggressively inverts, which mechanically jacks up the height of that longitudinal arch. We've covered a massive amount of structural terrain in this explainer today, from the powerhouse flexors to the delicate intrinsic stabilizers. You've now got a highly functional visual map of exactly how the foot is supposed to operate and exactly how to test every single failure point. So I'll leave you with this. The next time a patient walks into your clinic and you spot a subtle hammer toe or a flattened longitudinal arch, Which specific muscle's origin, insertion, and action are you going to test first? Thanks for joining me today. Keep structuring your learning, and I'll catch you in the next one.